Friends, hope you are all doing well. Today, our topic for discussion is reducing the risk of venous thromboembolism during pregnancy and the purpurium. The reference is Green Top Guidelines, the number 37A, published in April 2015. So for this guideline, the executive summary of recommendation is enough, and you have to understand this summary of recommendation, and only you have to do only the table and the executive summary. So that is enough for you people. But the important point is that you have to understand, you have to listen the lecture very carefully, that there are certain points, sometimes there may be confusion in that, what risk factors we will consider, and for how long we will give thromboprophylaxis. So these points are very important. So you have to listen the lecture very carefully. So executive summary of recommendation: what are the pre-pregnancy and antenatal risk assessment? Basically, whenever the patient came in pregnancy, so we have to take the detailed history from the patient to exclude any risk factor for any thromboembolism. So that we will start her on the thromboprophylaxis, like low molecular weight heparin, or subcutaneous or IV in the form of IV unfractionated heparin, to prevent the to reduce the risk of thromboembolism, to reduce the risk of pulmonary embolism or DVT. So this is very important. Whenever the patient came as at a booking, so you have to evaluate her for any risk factors in the patient, so that you have to start her on low molecular weight heparin. So in that case, the pre-pregnancy and the antenatal risks. So what are the risk factors for venous thromboembolism and in the pregnancy and purpurium, and what is the magnitude for these risk factors? So all women should undergo a documented assessment of risk factor for venous thromboembolism in early pregnancy or pre-pregnancy. So whenever the patient came as a pre-pregnancy, obviously she may have something, a known disease, like maybe she's having acquired antithrombin 3 deficiency. Some patients may present like this recurrent history of thromboembolism, and when they investigate these patients, so it came out to be chronic conditions like antithrombin 3 deficiency, protein S, protein C deficiency. So when they came as a pre-pregnancy, you have to tell everything before pre-pregnancy, and you have to make a plan for these patients, that what will you do at booking, what will we do, and what type of treatment we will start in pregnancy, and what are the drugs that are safe in pregnancy. So you have to tell everything to the patient, but in collaboration with hematologists. So it is not a single domain for obstetrician and gynecology. You have to involve the hematologist along with yourself. Then after that, risk assessment should be repeated if the woman is admitted to hospital for any reason or develop other intercurrent problems. So at any time, risk assessment when the patient admitted to the hospital is very important. Maybe it concurrent any other problem. Along with that, she may need thromboprophylaxis. Risk assessment should be repeated again intrapartum and immediately postpartum. So in these guidelines, they explain very detailed that what are the antenatal risk factors and what are the postnatal risk factors, and that you have to assess these risk factors. According to that, you have to start her on low molecular weight heparin. So any woman with 4 or more current risk factor, in appendix and table, we will later on discuss the table, but you have to focus on that any woman with 4 or more current risk factor other than previous venous thromboembolism or thrombophilia should be considered for prophylactic lower molecular weight heparin throughout the antenatal period, and is usually required prophylactic low molecular weight heparin for 6 weeks postnatally, but a postnatal risk assessment should be made. And then any woman with 3 current risk factors other than previous venous thromboembolism or thrombophilia should be considered for prophylactic low molecular weight heparin from 28 weeks, and will usually require prophylactic low molecular weight heparin 6 weeks postnatally, but a postnatal risk assessment should be made. And any woman with 2 current risk factors, as in the table, other than previous VTE or thrombophilia should be considered for prophylactic low molecular weight heparin for at least 10 days postpartum. And then Women admitted to hospital when pregnant, including to the gynecology ward with hyperemesis gravidarum or OHSS, should usually be offered thromboprophylaxis with low molecular weight heparin unless there is a specific contraindication such as risk of labor or active bleeding. And the last one is the risk of VT should be discussed with women at the reason for individual recommendation explained. So, before proceeding toward this guideline further, I will show you that this table before we proceed to the further, that what are the risk factors. At booking, what you have to evaluate in patient. So these are the risk factor. You have to memorize this, that any previous venous thromboembolism except a single event related to major surgery. So they said that whenever at booking the patient came, so you have to evaluate her for risk factor. So whenever the patient said that I have a previous venous thromboembolism history but beside from surgery, इसका मतलब ये है कि पेशेंट को प्रीवियस एक एपिसोड हुआ है वीनस थ्रोम्बोएम्बोलिज्म का, बट इट इज़ नॉट रिलेटेड टू एनी मेजर सर्जरी. सो दिस वन विल बी आर हाई रिस्क पेशेंट. सो ये हमारे पास हाई रिस्क पेशेंट होगा, ठीक है, क्योंकि इसका जो वीनस थ्रोम्बोएम्बोलिज्म है it has no relation to any major surgery. So it could be due to underlying any other condition. So we have to evaluate this, that maybe she is having any thromboembolic disease, any underlying, maybe she is having antithrombin 3 deficiency, maybe she is having protein S, protein C deficiency. In that cases they are more prone to recurrent thromboembolism. So you have to focus on that any previous venous thromboembolism except single event related to major surgery. So there will be no relation to major surgery. So in that case, this is the high risk patient. So what will you do? You will require this patient of this type of patient required antenatal prophylaxis with low molecular heparin and return to trust nominated thrombosis in expert team. So you have an involved multidisciplinary team and you have to start on low molecular weight heparin from the start. When the patient get pregnant and at booking she came, then you immediately start her on treatment, because these patients are more at high risk of thromboembolism in pregnancy. Then after that, these are the antenatal. So these are the antenatal assessment and the other one is postnatal assessment. Antenatal, you have to assess the patient, and then again you have to assess the postnatally, okay. So in postnatally, what you have to check, that any previous venous thromboembolism, any one requiring antenatal low molecular weight heparin, high risk thrombophilias and low risk thrombophilias plus family history of thrombophilia. So they are high risk and you have to give her low molecular weight heparin for at least 6 weeks. So you have to memorize the first one line, that in antenatally when she came, you have to assess if she has any previous venous thromboembolism and without any surgery, it is not related to surgery, then you have to immediately start her on treatment. And when after postpartum, you have to evaluate again, because already she is having previous VTE, so you have to continue thromboprophylaxis for at least 6 weeks. And they said that anyone requiring antenatal low molecular weight heparin, so you have to give her postnatal low molecular weight heparin for 6 weeks. And then those are high risk of thrombophilias. High risk thrombophilias are that antithrombin 3 deficiency, protein S or protein C deficiency. With that, there is recurrent episode of venous thromboembolism. The recurrent episodes of DVTs or in that case, these are high risk thrombophilias. We have later on discussed in the detail in recommendation, but because at initially you have to understand that what are the risk factor we have to consider. So that's why I first start with that table, that you will understand, then we will read all the recommendation and summary, so that will be easy for you. So in that case, you will give her at least 6. So these are the SBAs, okay. So this whole table is must came. SBA is okay. So for the first one is that high risk thrombophilia you have to start immediately, and then for 6 weeks you have to give thromboprophylaxis. Then after the second table said that when the patient is admitted in hospital, whether we are talking about pregnancy, they are pregnant, patient is pregnant, and she's having a risk factors, or in generally they said that those having single previous venous thromboembolism related to major surgery. In first one they said that the venous thromboembolism have no association with previous surgery, but in that they say that previous venous thromboembolism due to major surgery, high risk thrombophilias, but there will be no venous thromboembolism. In first one there is high risk thrombophilia, along with that she is having an episodes of recurrent episodes of thrombosis. But in the second one they said that they are high risk thrombophilias, but she is having no episode of any thrombosis or any recurrent thrombosis history, so that will be as a intermediate risk. The high risk one are that they are known they are having known thrombophilias, but with recurrent episodes of thrombosis. But intermediate risk are that she is having thrombophilia, but she had never episode of any thrombosis. Then after that, medical comorbidities, like patient is having for example cancer, heart failure, SLE, inflammatory bowel disease, inflammatory polyarthropathy, nephrotic syndrome, type 1 diabetes mellitus with nephropathy, sickle cell disease, and current IVDU, and any surgical procedure, for example appendectomy and ovarian hyperstimulation first trimester only. So these are your intermediate risk factors. And in intermediate factors, what you have to do in that case, you have to consider antenatal prophylaxis with low molecular weight heparin, and you have to consider low molecular weight heparin, but postnatal you have to assess this patient again. If, for example, if the patient is already antenatally, she is having medical comorbidity, so in that case this one is an intermediate risk, so you have to give at least 10 days postnatally, you have to give her thromboprophylaxis. So as we have already discussed in sickle cell disease, that those delivered vaginally will give her thromboprophylaxis for 7 days. But in those delivered by cesarean section, we will give extended thromboprophylaxis for 6 weeks. So you have to assess the patient. If a patient is having sickle cell disease, so postnatally you have to assess again. So if postnatally same medical comorbidities like heart failure, active SLE, IBD, so this is an intermediate risk, we have to give her at least 10 days of postnatally we are give 10 days of low molecular weight heparin. And along with that, for example, the patient is what are the intermediate risk factors for postnatal patient? So whenever the cesarean section in labor, BMI more than 40, readmission or prolonged admission in the puerperium, and any surgical procedure in the puerperium except immediate repair of the perineum. So if the postnatally the perineal tear and they are repaired, so you have not to give her, you are not considered as an intermediate risk factor. And other surgery, for example appendectomy or cholecystectomy, any type of surgery have been done in puerperium, so you have to consider low molecular weight whenever the patient has when patient gone in PPH and you have to the proceed toward the laparotomy, like you have applied B Lynch or internal iliac ligation. So in that case you will give her what we call as low molecular weight heparin. But those surgeries like sometimes the postnatally the patient with having ovarian cyst and severe pain, so in that you have to consider low molecular weight heparin. And those appendectomy, so in antenatally any procedure, any surgical procedure, for example appendectomy or cyst removal, so you have to consider, because these patients are admitted in hospital and they are more prone to thromboembolism, so in that case you consider thromboprophylaxis. But and in postnatal You have to consider also when any other surgery in the purpurium, except the perineal surgeries, like you have to repair the perineum, so you have not give low molecular weight heparin. But other surgeries that I have told you about, any appendectomy in postnatal purpurium, cyst surgery, so in that case you have to give. So these are the intermediate risk factors. You have to remember that in these case, postnatally you have to give for at least 10 days thromboprophylaxis. Then the third table is for low risk factors. Low risk factors are obesity, BMI more than 30, age more than 35, parity equal to or more than 3, smoker, gross varicose veins, current preeclampsia, immobility paraplegia, family history of unprovoked or estrogen provoked venous thromboembolism in first degree, low risk thrombophilias, multiple pregnancy, IVF, and ART. So these are the low risk factors. In that case, you have to check that how many factors you will consider. If there are in these factors there are more than 4 risk factors, then you have to start the thromboprophylaxis in first trimester. But if there are 3 risk factors in that patient, so you have to start her from 28 weeks. In intermediate factors, you will also start her. We will consider to assess the patient, and we will immediately start at booking when the patient came. In intermediate, we will also start at booking. But in this lower table, when there are 4 or more risk factors in this table, you have to consider thromboprophylaxis from first trimester. And if there are 3 risk factors, then you will consider thromboprophylaxis from 28 weeks. And then after that, 0 to 2 risk factors prophylaxis if admitted to hospital. Low risk factor, then you advise mobilization and avoidance of dehydration. So if less than 2 factors, then you have to advise only mobilization and avoidance of dehydration. So these are the points you have to remember, that if 4 or more risk factors, start from first trimester. But if 3 risk factor in this table, then from 28 weeks. And from 0 to 2 risk factors, then, or if admitted to hospital, then a mobilization or avoidance of dehydration. And these the same are for postnatal. Age more than 35, obesity, parity equal to more than 3, smoker, the same are in this table, but a bit some risk factors are added. So these type of patient you have to assess postnatally. In postnatal, if she is having age of more than 35, she is para 3 or more, and she is having preeclampsia, and the other thing is she is having multiple pregnancy. So she is having 4 risk factors. So for that 4 risk factors, you have to start her on low molecular weight heparin. So you have to assess again postnatally. As age cannot be changed, that would be same. Parity is not changed, as that would be same. If the patient is having current preeclampsia, so maybe she is postnatally, there may be chance that the preeclampsia persists. And multiple pregnancy, so in that case postnatally, there may be in multiple pregnancy the other risk factors are added, the multiple pregnancy. So in that case postnatally, if the 4 risk factors are continued, if they have already these 4 factors, then you have to consider postnatal also, antenatal low molecular weight heparin, but for at least 10 days, not more than that. Okay. In that case, if 2 or more risk factors in postnatal, then you have to consider low molecular weight heparin for at least 10 days. So you have to assess the patient antenatally and also postnatally. So these are the patient that transient risk factor like dehydration, hyperemesis, current systemic infection, long-term distal. So these are the transient risk factors. Then after that, they in this table, that if 2 or more risk factors, this will go up. Postnatally, if she is having 2 or more risk factor in these, so you have to give her low molecular weight heparin for at least 10 days. But if she is having less than 2 risk factors, then she is having a low risk patient, and you will advise mobilization or avoidance of dehydration. So these are the important points, that for in antenatally we need 3 risk factors, We need 4 risk factors to start her immediately in first trimester, and 3 risk factors for to start her low molecular weight heparin from 28 weeks. But if she is having less than 2 factors, then in pregnancy we will tell the patient that she should mobilize and avoid dehydration. She should she should be must well dehydrated. And in postnatally, if she is having these risk factors, persistence of these risk factors, and if it is more than 2 risk factors, then you have to give her low molecular weight heparin for at least 10 days. So the arrow is for the upper one, okay? And if it is having fewer than low risk factors, then you have to advise her early mobilization and avoidance of dehydration. And B, if persisting more than 3 risk factors, consider extended thromboprophylaxis with low molecular weight heparin. So you have, if the patient is having more than 3 risk factors, they said that then you have to consider extended thromboprophylaxis, but it will be depend on the patient and in collaboration with hematologist. But and ideally, at least 10 days you have to give uh, antenatal thromboprophylaxis. So they are talking about these type of things in that table. So we will again read this table that you have to understand that risk assessment repeated again intrapartum, and you have to assess in antepartum and then in intrapartum and immediate postpartum. So with 4 or more current risk factors other than previous VT or thrombophilia, the should be considered prophylactic lower weight heparin throughout the antenatal period, and required low molecular weight heparin for 6 weeks postnatally, but a postnatal assessment should be done. So they said that if she's having 4 or more risk factors in antenatally, then the last one table, so you have to give her low molecular weight heparin for at least 6 weeks. So you have to note that point, that in case of 4 risk factors, in the lower one table, if the patient is having 4 risk factors, so you have to start her immediately low molecular weight heparin in first trimester, and you have to continue for at least 6 weeks. And other depend upon the postnatal risk assessment. And all women with 3 current risk factors, and those with having a 3 current risk factor, you have to consider low molecular weight heparin from 28 weeks and required postnatal for at least 6 weeks postnatal. So those having 3 risk factors and 4 risk factors, those having 3, so postnatally you have to give her low molecular weight for 6 weeks. But if she is having 2 risk factors without any other previous VT or thrombophilia, should be considered low molecular weight heparin for at least 10 days postpartum. So in that table, we have discussed that if the patient is having more than 3 risk factors, so you have to give her thromboprophylaxis for at least 6 weeks. But if she is having two factors, two or more than 2 factors risk factors, then you have to give for at least 10 days. And if fewer than 2, you have to give for at least you advise her early mobilization. And the other thing is that avoid dehydration. So the table I have discussed already, so hope you find you understand this point. And if you have any queries in that, so you must have ask in a group, so that you can understand very clearly, because these are your SBAs, that they have given you risk factors, so you have to memorize these risk factors, that what are the risk factors. In sometimes the SBA came as the patient is para 3, age more than 35, and she's having preeclampsia along with multiple pregnancy. So for how long, when you will start low molecular weight heparin, and for how long you have to give. So you, in that option, you have to select that we will immediately start her treatment, and for at least 6 weeks we have to give the thromboprophylaxis. And if there are 3 risk factors, you have to start in 3 risk factor, you have to start low molecular weight heparin in second trimester from 28 weeks, in third trimester from 28 weeks, and then for at least 6 weeks you have to give in if she is having more than 3 risk factors. But if the patient is having 2 risk factor and postnatally In 2 risk factor, antenatally, you have to tell the patient that she should mobilize and avoidance of dehydration. But if in postnatally she is having the same these two factors, two current risk factors, or equal to or more than 2 risk factor, then postnatal you have to give thromboprophylaxis for at least 10 days. So then they are saying previous venous thromboembolism. The first paragraph, the first table, the first line that we have discussed, that women with previous venous thromboembolism should be offered pre-pregnancy counseling and a prospective management for thromboprophylaxis in pregnancy made. Those who become pregnant before receiving such counseling should be referred at the earliest opportunity in the pregnancy to a clinician with expertise in thrombosis in pregnancy. So women with a previous venous thromboembolism, except those with a single venous thromboembolism related to major surgery and no other risk factor. This one risk factor is an intermediate, but those having a previous VTE with no relation to major surgery should offer thromboprophylaxis with low molecular weight heparin throughout antenatal period. And women with previous venous thromboembolism should have a careful history documented. Where objective documentation is not available, the previous diagnosis of venous thromboembolism can be assumed in cases where the woman give a good history and receive prolonged greater than 6-week therapeutic anticoagulation. So if the patient having a documentation of the documentation is not available, but the patient said that I have a previous attack of thromboembolism, then you have to immediately start her on low molecular weight heparin, and for at least postnatal you have to give for at least 6 weeks low molecular weight heparin. Then thrombophilia associated venous thromboembolism. So hereditary thrombophilias, women with previous venous thromboembolism associated with antithrombin 3 deficiency, these are thrombophilias. Antithrombin 3 deficiency who will often be on long-term oral anticoagulant should be offered thromboprophylaxis with a high dose of low molecular weight heparin, either 50%, 75% of full treatment dose, and antenatally and 6 weeks postpartum until return to oral anticoagulant therapy after delivery. So these type of patient, those with the antithrombin the 3 deficiency and having previous along with that she is having a previous episode of venous thromboembolism, so you have to, and the patient must be usually on oral anticoagulant therapy, so you have to switch to low molecular weight heparin, and you will give increased dose in these type of patient, those having antithrombin deficiency. So that is either 50% or 75% or full treatment dose. So this is one of your SBA that you have to check in MCQ if they have given you the patient is having antithrombin 3 deficiency along with the previous episode of venous thromboembolism. So for how long you will give her treatment, and what is the dose of that, what is the dose for that specific antithrombin 3 deficiency. So you have to opt for this option. If the option is in the option they have written you 50%, 75% or full treatment dose and 6 weeks postnatally, so you have to click that one. So this one is your SPA. Management should be undertaken in collaboration with the hematologist with expertise in thrombosis in pregnancy, and consideration given to antenatal anti-10A monitoring and the potential for antithrombin replacement at initiation of labor or prior to cesarean section. So depend upon the situation, routinely anti-10A monitoring is not required if you are starting her on low molecular weight heparin. In that, because there is less likely chance that the dose exceed, because but in that case we give 50 to 75% dose and full treatment dose. So in that case you have to monitor her anti-10A level monitoring and or for antithrombin replacement at initiation of labor or prior to C-section. So if the anti-10A level is increased, so in that case you have to consider to change to other form of drug, like in the form of IV and fractionated heparin. So in that case, for you have to memorize that for low molecular weight heparin we will monitoring with anti-10A level, And in IV unfractionated heparin, we will monitor only platelet count, because in IV unfractionated heparin, they will affect the platelet count. But in low molecular weight heparin subcutaneously or in the form of IV, they will affect the anti-10A level. So we will monitor her anti-10A level. But in warfarin, we have to check her INR or PT-INR, APTT or INR. For IV unfractionated, we check her APTT and platelet count, and for warfarin we check her INR level. So you have to memorize these things, that for which anticoagulant we will monitor which type of investigation. If anti-10A level are measured, a test dose not use exogenous antithrombin should be used, and a 4-hour peak level of 0.5 to 1 aim for. So you have to check her after starting hormone treatment. So your aim should be that anti-10A level should be at least 0.5 to 1. Other heritable thrombophilia defect are low risk and can be managed with standard dose of thromboprophylaxis. So the heritable, we are, later on we will discuss that what are the heritable thrombophilia defects and what are acquired. So in later on in table we will discuss that. And what is acquired thrombophilias? Acquired thrombophilias, women with the venous thromboembolism associated with antiphospholipid antibody syndrome. So this is the acquired, and the antithrombin is heritable. So it can inherit in family history, that they will be inherited through family. But the acquired thrombophilia is antiphospholipid antibody syndrome, and in that case, with the antiphospholipid syndrome, the patient is having APS, and along with the history of episode of thrombosis. In that case, you will also offer thromboprophylaxis with high dose, either 50%, 70%, or full treatment antenatally and for 6 weeks postpartum until return to oral anticoagulant therapy after delivery. So after delivery, when the patient her bleeding is improved, then you have to again change her on oral therapy like warfarin. But in pregnancy, usually in first trimester, warfarin is avoided because it causes embryopathy, fetal embryopathy. So that's why in first trimester we will avoid warfarin therapy. So you have to in either option, you will you will continue her warfarin, but in first trimester you have to stop warfarin. You will give her start her on low molecular weight heparin. But once the first trimester pass, then you again change her to warfarin if the dose is not too much high, because later on the warfarin is safe. But with warfarin is that we will need intensive monitoring the form of INR. So that will be a bit risky for the patient, because there may be sudden bleeding with the warfarin. So in that case, the better option is low molecular weight heparin, because it need less monitoring. Sometime we will not do anti-10A monitoring, will not be required because it is the safest and have not any bleeding episode. But with warfarin, you will have to do her INR level and IV and unfriction. In that case, the low molecular weight heparin is expensive, but warfarin is less expensive, and low molecular weight in the form of injections are expensive. Then in that case, you have to tell the patient if she want warfarin, and so you have to again change to first trimester you will give low molecular weight heparin, then you again change to warfarin. But you will tell the patient that we will need you have to come for follow-up visit to monitor her INR, and according to INR you have to adjust the dose. But in low molecular weight heparin, you will be happy that is the safest drug and less like risk of bleeding episodes with low molecular weight heparin. So that's why if the physician and the hematologist prefer low molecular weight heparin in pregnancy. So, and once the pregnancy in postpartum her bleeding settled, then you have to again change her on oral therapy when on pre-pregnancy, because already she is taking oral anticoagulant therapy, so you have to continue with that. Pregnant women with APS and prior venous thromboembolism or arterial thrombosis should be managed in collaboration with the hematologist, rheumatologist, and expertise in this area. So we involve multidisciplinary team. At a previous recurrent venous thromboembolism, advice regarding dose of low molecular weight pregnancy should be sought out from a clinician with expertise in hemostasis and pregnancy. Some women with previous recurrent VTE required high dose of low molecular weight heparin. And women on long-term warfarin or other anticoagulant should be counseled about the risk of these agents to the fetus and advised to stop their oral anticoagulant therapy and change to low molecular weight as soon as possible pregnancy is confirmed, ideally within 2 weeks of the missed period and before the 6 weeks of pregnancy. So up to 6 weeks you have to avoid oral therapy, and you have to tell the patient that we have to change her onto other drug like low molecular weight heparin and they are safe. Women not on warfarin or other anticoagulants should be advised to start low molecular weight heparin as soon as possible as she is having a positive pregnancy test. Then how should women with previous VTE be stratified to determine management in pregnancy? So, women with venous thromboembolism associated with antithrombin deficiency or antiphospholipid syndrome or recurrent VTE who are often on long-term oral anticoagulant should be offered thromboprophylaxis with high dose. So, these are the three things. Whenever the MCQ came, this one will be your SBA. That whenever there is having previous venous thromboembolism, along with that she's having antithrombin deficiency, APS and recurrent VT, so you have to give the dose of low molecular weight. How much? 50%, 70% or full treatment dose antenatally and for 6 weeks postpartum until return to oral after delivery. These women require specialist management by expertise in hemostasis and pregnancy. Women in whom original venous thromboembolism are unprovoked, idiopathic, and related to estrogen containing contraception are related to a transient risk factor other than major surgery or who have other risk factors should be offered thromboprophylaxis with low molecular weight heparin throughout the antenatal period. So the other point is that those patients having venous thromboembolism but that was unprovoked means there will be no other cause underlying, like there will be no history of any thrombin deficiency or it is not related to any major surgery. They said that unprovoked or idiopathic, or it will be related to estrogen containing contraception. Patient is taking estrogen and because with COCP is an increased risk of thromboembolism, so with estrogen they develop thromboembolism. So this one is a transient related to transient risk factor other than major surgery. So you have to give low molecular weight throughout the antenatal period. And in whom original venous thromboembolism was provoked by major surgery from which they have recovered and who have no other risk factor, thromboprophylaxis with low molecular weight heparin withheld antenatally until 28 weeks provided no additional risk factors are present, in which case they should be offered low molecular weight heparin. They require close surveillance for the development of other risk factors. So in that case, those with having this, so they are telling about that this one, single venous thromboembolism related to major surgery. So they said that you have to start her on, better to start her low molecular weight heparin from 28 weeks. And that say that consider antenatal low molecular weight, they only tell that we'll consider antenatal, but they didn't mention the time. So in that case, they mentioned the time that with that venous thromboembolism provoked by major surgery and she is having no other risk factors, then you have to start her on start a low molecular weight heparin from 28 weeks. So this one is your SBA, that whenever the VTE provoked by major surgery in previous pregnancy, you have to start antenatal low molecular weight heparin from 28 weeks. And if she is having the VTE with major surgery, but along with that she's having other risk factor, like maybe she's having age of more than 35, like she's having parity of more than 3. So along with other risk factors, so you have to consider early. You have to start her immediately in the first trimester. But if there is only single risk factors like only major surgery, the venous thromboembolism due to major surgery in previous pregnancy and no other risk factor, then you have to consider low molecular weight heparin from 28 weeks. Testing for thrombophilia in women with prior VT. Women with prior venous thromboembolism require thrombophilia testing. So, if the patient sometimes came as a first postnatally or antenatally, without any pre-pregnancy, that she is having an episode of venous thromboembolism, so you have to consider her for thrombophilia screening. This is very important, and you have to ask from the patient that any family history of venous thromboembolism or having any thrombophilias in family. So in that case, you have to investigate these type of patient. So prior to testing for thrombophilia, women should be counseled regarding the implication for themselves and their family member of a positive or negative result. The result should be interpreted by a clinician with specific expertise in the area. Women with a family history of venous thromboembolism and either antithrombin deficiency or where the specific thrombophilia has not been detected should be tested for antithrombin deficiency. So you have to test for thrombophilia if the patient have previous episodes or having family history of thrombophilia, so you have to evaluate the patient for antithrombin deficiency. Women with an unprovoked venous thromboembolism should be tested for the presence of antiphospholipid antibodies. So with unprovoked VTE, there could be a chance that it could be antiphospholipid antibody syndrome, so you have to evaluate the patient for this. Those they are asymptomatic hereditary thrombophilia, as we have discussed in that so asymptomatic, this one asymptomatic. These are the high risk thrombophilia, they are symptomatic with previous episode of VTE, but they those type of thrombophilias that are high risk thrombophilia, but there will be no there will be no history of any episode of venous thromboembolism. So we will consider these patients as asymptomatic. Women should be stratified according to the level of risk associated with thrombophilia and the presence or absence or family of history or other risk factor. Women with asymptomatic antithrombin protein C or S deficiency or those with more than one thrombophilia defect, including homozygous factor V Leiden, homozygous prothrombin gene mutation, and compound heterozygous, should be referred to local expert, and antenatal prophylaxis should be considered. And this should be recommended for 6 weeks postnatally, even in the absence of additional risk factor. So those they are symptomatic and having antithrombin deficiency, protein C, protein S, homozygous factor V, so you have to immediately start her on treatment. In first trimester and postnatally, you have to give for 6 weeks. But they are telling that those are asymptomatic. Asymptomatic with antithrombin, protein C, S, and homozygous factor V, homozygous prothrombin. So you have to refer for local expert. The expert like hematologist decide whether she need antenatal thrombophylaxis or not, but for in postnatal you have to give her 6 weeks postnatally the low molecular weight heparin. So this is also one of your SBA, that for how long, in whom patient in asymptomatic antithrombin, what are the treatment option. So they have categorically written in that MCQ that refer to local expert, antenatal thromboprophylaxis considered, and for 6 weeks postnatally. So you have to mark this one. So these are your SBAs. You have to understand that what they want. There are certain points that you have to remember this and choose the option according to that. So these are the points which I am telling you, these are very important. Then after that, heterozygosity. So homozygous factor V Leiden and homozygous obviously are high risk for thrombophilias, but thromboembolism. So those are heterozygous for factor V, prothrombin gene, heterozygous for prothrombin gene, or antiphospholipid antibodies are considered as a risk factor for thrombosis in asymptomatic women, and in the presence of 3 other risk factors such as factors, such women may consider for antenatal thromboprophylaxis. If there are 2 risk factors, thromboprophylaxis should be considered from 28 weeks, and if there is no other risk factor, postnatal thromboprophylaxis for 10 days should be considered. So they are said that those are heterozygous, prothrombin and anti are a risk factor from thrombosis. So in the presence of these three risk factors are present, so you have to start her on antenatal thromboprophylaxis. And if two risk factors, you will consider from 28 weeks, and if one risk factor, postnatal for at least 10 days. So this paragraph is also important, SBA, that in previous we discussed homozygous factor 5, homozygous prothrombin. So they say that you have to send her to referral to the local expert, and for 6 weeks you have to give the treatment. But they say that those are having asymptomatic and having a history of heterozygous factor 5 and prothrombin antiphospholipid. So in that, according to that, they are having three risk factors, so you have considered antenatal prophylaxis. And if two risk factors, you have to consider from 28 weeks, and one risk factor, so you give only postnatally. Antenatal you will not give the treatment. Women with no personal history or risk factor for venous thromboembolism, but who have a family history of an unprovoked estrogen provoked in first degree relative when under 50 years of age should be considered for thrombophilia testing, and there will be more information if the relative has thrombophilias. What about the antiphospholipid antibodies? Persistent antiphospholipid antibodies, lupus anticoagulant, anticardiolipin, beta 2 glycoprotein. This is also one of your SBA, that it is from mastering, that what is the lupus anticoagulant, the persistent antiphospholipid antibodies, that lupus anticoagulant, what is that antibody? So that is a beta 2 glycoprotein 1 antibodies. They are asked about that in which type of antibodies are present in antiphospholipid antibody syndrome. So that are beta 2 glycoprotein 1 antibodies. And in women without previous VTE should be considered as a risk factor for thrombosis, such that if she has other risk factors, she may consider for antenatal and postnatal thromboprophylaxis. So they said that she is having antiphospholipid antibody syndrome but without any risk factor. So without any risk factor, you have not to start her on treatment, but with any other risk factor, you may consider thromboprophylaxis in these patients. Otherwise, not indicated. But if she's asymptomatic APS and due to other reason that she's having recurrent miscarriage, so for recurrent miscarriage, you have to treat. Otherwise, if simple antiphospholipid syndrome, she has no history of venous thromboembolism associated with it, so no need of thromboprophylaxis. You have to monitor the patient. But along with that, with other risk factors like she is having recurrent miscarriage, so you may start her on the APLS treatment in pregnancy like aspirin or low molecular weight heparin. What are the time of initiation of thromboprophylaxis? Antenatal thromboprophylaxis with those with previous venous thromboembolism should begin as early in a pregnancy in practical, and we already discussed in that table. And women without previous VTE or without particular first trimester risk factor or admission to the hospital but with 4 other risk factors should be considered antenatal throughout pregnancy. So these are 3 points that from when you will start her. So with previous VTE, you have to immediately start in first trimester, and those with the previous VTE and without particular first trimester risk factor admission to hospital but with 4 other risk factor should be considered antenatally throughout pregnancy. Then women without previous VTE and without particular first trimester risk factor or admission to hospital but with 3 risk factors can start antenatal at 28 weeks of gestation. So those they are telling about the last one table, that those with 4 risk factor you have to start immediately in first trimester, and those with 3 risk factor in antenatal you have start consider from 28 weeks. First trimester risk factors. What are the first trimester risk factor and how should be managed? Women admitted with hyperemesis should be considered for thromboprophylaxis with low molecular weight heparin and continue when the hyperemesis resolves. So only in hyperemesis, this is a differentiating point, that with hyperemesis, those on admitted in hospital, you will only give thromboprophylaxis. Otherwise, when she discharged, you have to stop the treatment. Women with OHSS should be considered for thromboprophylaxis low molecular weight heparin in first trimester. And women with an IVF pregnancy and other three risk factors should be considered for thromboprophylaxis with low molecular weight starting in. So consider only IVF. If she's only IVF with no other risk factor, you have not to start. But IVF along with other three risk factors, you have to start her on low molecular weight heparin in first trimester. What other thromboprophylaxis should be interrupted for? So thromboprophylaxis during labor delivery, including the use of renal analgesia. Women receiving antenatal thromboprophylaxis would be advised if they have any vaginal bleeding or once labor begin, they should not inject any further low molecular weight heparin. They should be assessed on admission to hospital and further dose should be prescribed by medical staff. So you have to tell the patient that she is that whenever the if she is taking warfarin, so obviously warfarin we have to stop at 36 weeks. We will stop warfarin and we have to change into low molecular weight heparin, because once the patient with warfarin get into labor, they increase risk of bleeding and increase risk of fetal thrombocytopenia, intracranial hemorrhage in fetus. So if and you choose that regime that the patient is not affording, so you have to stop her warfarin in first trimester, then you have to start her warfarin and again stop at 36 weeks and again start her on low molecular weight heparin, and preferably and that after 36 weeks IV unfractionated heparin should be given, because with the IV there is immediate reversal. If the dose if the patient get into labor, so it can be immediately reversed. IV heparin antidote is protamine sulfate, but low molecular weight heparin required much time. So after 36 weeks, preferably that you have to start her on IV and fractionated heparin, so that if the doses get high and the patient accidentally get into labor and she didn't skip that dose, so for that you will give her protamine sulfate, so immediately reversal of that occur. And for warfarin, you have to memorize that this type of MCQs may come, that for what is the antidote for warfarin, so that is better is FFPs. If the patient is bleeding, if the patient is not bleeding, then is injection vitamin K can be given. So these are the points that you have to tell the patient, that whenever she present, whenever she feel that there is a pain in her abdomen and any spotting, so she should skip that dose of low molecular weight heparin. Regional technique should be avoided if possible until at least 12 hours after the previous prophylactic dose of low molecular weight heparin. So you have to wait for at least 12 hours. Low molecular weight should be not given for 4 hours after use of spinal anesthesia or after epidural catheter have been removed, and the catheter should not be removed until within 12 hours of the most recent injection. So they said that this is also one of your SPAs, that regional techniques should for how long the regional technique should be advised to avoid, that is at least 12 hours. And after surgery, that if for at least 4 hours you have to wait, and after 4 hours you have to start her on low molecular weight heparin in case of spinal anesthesia. But in case of epidural catheter, so you have to wait for at least 12 hours and will not remove the you will give the injection within 4 hours, but catheter should not be removed for at least 12 hours within the most 12 hours of recent injection. Women with the present while on therapeutic regime of low molecular weight heparin, regional technique should be avoid possible for at least 24 hours after the last dose of low molecular weight heparin. So in prophylactic, this one also an SBA, that if the patient is taking prophylactic dose of low molecular weight heparin, so you have to wait for at least 12 hours, but in therapeutic you will at least 24 hours you have to wait for the whenever the last injection, when did she receive the last injection, you have to ask from the patient. If the 12 hour, if she is on prophylactic dose, 12-hour window is enough, and then you have to give her spinal anesthesia. But if she is on therapeutic low molecular weight heparin, then you have to wait her for at least 24 hours. So in that case, this could be a planned delivery in these type of patient. So you have to plan a delivery, because these patients may suddenly go into labor, and it is very difficult to manage these patients then. Women receive antenatal low molecular weight heparin have an elective cesarean section should receive a thromboprophylactic dose of low molecular weight and the day prior to delivery. On the day of delivery, any morning dose should be emitted and operation performed that morning. So, if you are planning elective cesarean section, so in that case, you have to omit the morning dose. Tell the patient that she should have omitted the morning dose. You will not give her. You have to tell the nurse and staff, because already obviously for elective c-section you have to admit the patient early. So in that case you have to tell the nurse, and you have to strictly written on the file that no low molecular weight heparin in the morning, skip that doses. First low molecular weight heparin dose of the first thromboprophylactic dose of low molecular weight should be given as soon as possible after delivery, provided there is no postpartum hemorrhage and regional anesthesia has been not used. Women at high risk of hemorrhagic risk with risk factor including major antepartum hemorrhage, coagulopathies, progressive wound hematoma, suspected intra-abdominal bleeding, and postpartum hemorrhage may be managed with embolic stocking, foot impulse device, and intermittent pneumatic compression devices. Unfractionated heparin may also be considered. So if you are suspecting that the patient in postnatally that increased risk of antepartum that increase the patient risk factors like coagulopathy, previous progressive hematoma, intra-abdominal bleeding, so you will manage these patients with anti-embolic stockings or compression. But unfractionated unheparin can be considered because it is a bit safe, and there is immediate reversal available, so you can consider unfractionated heparin. If the woman develop a hemorrhagic problem while on low molecular weight heparin, the treatment should be stopped and expert hematologist advice of sort. So in that case, you have to stop the patient hemorrhagic problem. Thromboprophylaxis should be started or instituted as soon as the intermediate risk of hemorrhage is reduced. So, within 4 hours of spinal anesthesia, you have to start a low molecular weight heparin. And for at least after 3 to 4 days, you have to switch to oral anticoagulant therapy once the bleeding is reduced. Thromboprophylaxis after delivery. What are the risk factors for venous thromboembolism after delivery? All the women with class 3 obesity equal to or greater than or equal to 40 should be considered for low molecular weight and appropriate for their weight for at least 10 days after. So this is the postpartum. After delivery, you have to assess if the BMI is more than 40. You have to give without any other risk factors. So you have to give her low molecular weight heparin for at least 10 days. And with 2 or more persisting risk factors, should be considered for low molecular weight heparin in the prophylactic dose appropriate for their weight for 10 days after delivery. So a persisting dose means that antenatally she is having a risk factor, and persistently she is obviously age, parity, these are cannot be changed as she is having multiple pregnancy. So in that case, you will give her low molecular weight heparin for at least 2 days. So they are telling you about this type of that they are postnatally they are persisting 2 or more risk factor, then you have to give for at least 10 days. You will give her low molecular weight heparin. And what in postnatally with the previous VTE, all women with previous history of confirmed VD should be offered low molecular weight heparin or warfarin for at least 6 weeks postpartum, regardless of the mode of delivery. And what about with asymptomatic thrombophilias? Women with thrombophilias without previous VT should be stratified according to both the level of risk with their thrombophilia and the presence or absence of family risk factors or other risk factors. So women with a family history of VT and inherited thrombophilia should be considered for 6-week postnatal thromboprophylaxis. So they are telling you about that paragraph. This one, that postnatally, if she is having low risk thrombophilias but having this one, high risk thrombophilia, low risk thrombophilia, but family history of thrombophilia and with the high risk thrombophilia history of VT, so you have to consider low molecular weight heparin for at least 6 weeks. Then what about the cesarean section? All women have cesarean section should be considered for thromboprophylaxis with low molecular weight for 10 days after delivery, and those have elective C-section who should be considered for thromboprophylaxis with low molecular weight happening for 10 days after delivery if they have additional risk factor. So this is the important point SBA, that if the patient is having who have a cesarean section should be considered low molecular weight for have 10 days after delivery, but those undergone elective c-section should be considered if there is any additional risk factor. So I have to, they are asked about this paragraph. If the patient is having elective c-section, emergency c-section, cesarean section in labor, so you have to give for at least 10 days. But if in that case, so in that case, when they said that elective c-section has been done, so only elective c-section is not an indication for thromboprophylaxis, but along with elective c-section, other risk factor like her age is more than 35 or her parity is more than 3, then you have to give thromboprophylaxis for 10 days. So they are, so you have to understand these points. These are very important, that in whom you will consider what type of treatment. Okay, so they said that if cesarean section, elective emergency cesarean section has been done, so in labor, so you have to give 10 days, and for elective c-section with other risk factor, then you have to consider low molecular weight heparin. How long should thromboprophylaxis should be continued after delivery? Risk assessment should be performed in each woman for at least one following delivery and before discharge to made for low molecular weight prescription and administration. Thromboprophylaxis should be continued for 6 weeks in high risk women and for 10 days in intermediate risk women. As we have seen in the table, that the first one table, we will postnatally will give at least for 6 weeks, and for intermediate risk factor we'll give for at least 10 days. In women who have additional persistent lasting more than 10 days postpartum risk factors such as prolonged admission, wound infection or surgery in the perfurium, thromboprophylaxis may extend up to 6 weeks until the additional risk factor are no longer present. So this is also important point, that if the patient is having a persistent risk factor and you are suspecting that it will last for more than 10 risk factor like prolonged admission, she may need prolonged admission, and the wound is infected, or the surgery in the purpurium, so in that case you will extend the thromboprophylaxis for at least 6 weeks. Okay, so then after that, what agent should be used for thromboprophylaxis? Low molecular weight heparin are the agent of choice for antenatal thromboprophylaxis. Dose of low molecular weight are based on weight. For thromboprophylaxis, the booking or the most recent weight can be used to guide the dosing. You have to take her booking weight, and according to booking weight you will adjust the dose of thromboprophylaxis. It is only necessary to monitor the platelet count if the woman has prior experience to unfractionated heparin, and monitoring of anti-10A level is not required when the low molecular weight heparin is used for thromboprophylaxis. And if it is used as thromboprophylaxis, it is not required, but she is taking for long time therapeutic, then you have to monitor her anti-10A level. And for unfractionated heparin, you will to monitor her platelet count. And dose of low molecular weight should be reduced in women with renal impairment, and low molecular weight are safe in pregnancy. So this one is also important SBA, that you have to reduce the dose of low molecular weight with renal impairment. Unfractionated heparin, in a woman at high risk of thrombosis, unfractionated may be used peripartum in the presence to low molecular weight heparin when there is an increased risk of hemorrhage or when regional anesthetic technique may be required. If unfractionated after cesarean section or other surgery, the platelet should be monitored every 2 to 3 days from day 4 to 14 or until heparin is stopped. So they said that if high risk of thrombosis, so better to choose the IV form, because with low molecular weight heparin subcutaneous, you have suspect that there is increased risk of hemorrhage, or you are planning for regional anesthesia. So in that case, IV unfractionated heparin is best. Donaparide. Potential use of donaparide should be used in consulted with hematologists and expertise in. So depend upon that what the expertise but the treatment are available in our setup. We will advise low molecular weight heparin IV and fractionated heparin. So fondaparinux should be reserved for women intolerant to heparin compounds. Fondaparinux is used in pregnancy, should be conjunction with consultant hematologist, expertise in hemostasis. Low dose aspirin is not recommended for thromboprophylaxis. Warfarin use in pregnancy is restricted to the few situations where heparin is considerable unsuitable. Some women with mechanical heart valves. So warfarin can only be used considered in those patients when heparin is unsuitable, for example in mechanical heart valves. So if the patient is having mechanical heart valves, so you may consider warfarin throughout pregnancy, but at a lowest dose 5 mg, less than 5 mg is safest you can use throughout pregnancy, but individualize and you will collaborate with cardiologists and hematologists that whether so that you will not get harm to the baby, because with warfarin fetal embryopathy, so they said that it is restricted in few situations. So um, you have a clear concept about that it is an SPA, that warfarin is used in restricted situation when heparin is considerably unsuitable, for example mechanical heart valves. So you have to consider warfarin. Women receiving long-term anticoagulation with warfarin can be converted from low molecular weight heparin to warfarin postpartum when the risk of hemorrhage is reduced, usually 5 to 7 days after delivery. So this is also one of your SBA, that when you have to change the low molecular weight to warfarin. So when the risk of hemorrhage is reduced, ideally 5 to 7 after delivery. So this is the SBA, 5 to 7 after delivery. Warfarin is safe in a pregnancy. What are dextran? Dextran should be avoided antenatally interpartum because of risk of anaphylactoid reaction. Other oral thrombin and 10 inhibitors, non-vitamin K antagonists should be avoided in pregnant women. Use of non-antithrombotic is not currently recommended who are breastfeeding. Antithrombotic stocking, the use of properly applied anti-embolism stocking of appropriate size and provided graduated compression with a calf pressure of 14 to 15 mg recommended, and the purpurium for women who are hospitalized and a contraindication to low molecular weight heparin. These include women who are hospitalized post-cesarean section combined with low molecular weight heparin and considered to particularly high risk of VT, previous VT, more than 4 risk factor antenatally or more than 2 risk factor postnatally, women with traveling long distance more than 4 hours. So you have to consider the antithrombotic any anabolic stocking. So this is the also your SBA, that in whom you women traveling long than more than 4 hours, then you have to consider anti-embolic stocking. Contraindication, low molecular weight should be avoided, discontinued, or postponed in women at risk of bleeding after careful consideration. Women with previous or current allergic reaction to low molecular should be offered an alternative preparation or alternative form of prophylaxis. Further advice on the management of women with both VTE risk factors and bleeding risk factor or allergy may be sought from a hematologist with expertise. So there are certain contraindication you have to evaluate the patient. So risk scoring methodology, a formal VTE risk assessment with numerical scoring for all pregnant as recommended. So now we have to check that later on what are the score and what are. So these are the risk factors, pre-existing risk factors. She is having previous VTE, thrombophilias, these are heritable, antithrombin, protein C, S, factor 5, prothrombin, and these are the acquired. APLS, persistent lupus anticoagulant, high titer of anticardiolipin antibodies, and beta-2 glyco-1 protein. Medical comorbidities, for example, cancer, heart failure, active SLE, inflammatory, IBD, nephrotic, type 1 diabetes, age more than 35. Obesity, these are pre-existing risk factors. Obesity more than 30, either pre-pregnancy or early pregnancy. Parity more equal to more than 3, a woman. Para 3 after her third delivery. Smoking, gross varicose veins, paraplegia. So these are pre-existing risk factors. And what are the obstetric risk factor? Multiple pregnancy, current preeclampsia, cesarean section, prolonged labor, mid-cavity rotational operative delivery, stillbirth, preterm birth, postpartum hemorrhage more than 1 liter required. So these are the obstetric, these are the antenatal plus postnatal. Caesarean section, prolonged labor, mid-cavity forceps applied, stillbirth, preterm birth, new onset or transient risk factor. These risk factors are potentially reversible and may develop at later stages in gestation that initial risk assessment may resolve. And therefore, what is important is an ongoing individual risk assessment. So any surgical procedure in pregnancy, puerperium, except immediate repair of the perineum, appendectomy, postpartum sterilization, bone fracture. So any procedure we have already discussed in the that table that in pregnancy and puerperium, so you have to consider low molecular weight heparin. Hyperemesis dehydration only when the patient is admitted in hospital. OHF says first trimester only you have to give IVF. In IVF along with other risk factors, then you have to consider low molecular weight heparin. Admission or immobility more than 3 bed rest, pelvic girdle pain, for example, restricted mobility, current systemic infection requiring IV antibiotic or admission to hospital, for example, pneumonia, pyelonephritis, or wound infection, and long distance travel more than 4. So these are the new onset or transient risk factor, and you have to assess the patient. Then after that, these are the same thing we have already discussed. Nothing in the same, almost nothing in detail. Only the recommendation and summary is if you understand the recommendation and summary in what pattern I have taught you. So you have to memorize this for SBA. This is enough. So you have not to read these all details. Nothing new in this detail. Same they have repeated. Okay. So now, okay, so how you will give her prophylactic dose for in case you are thromboprophylactic dose for antenatal and postnatal. So if she is less than 50 kg, enoxaparin, deltaparin, and tinzaparin, these are low molecular weight heparin, different forms. So if she is less than 50 kg, you have to give 20 mg, 2500, 35. So these are the, according to kgs, you have to adjust the dose. But if she required high prophylactic dose weighing 50 to 90 kg, then 40 mg, 12 hourly, 5000 12 hourly, and 4500 12 hourly. And more than 70 kg, you have to, according to that, you will give 0.75, 0.675 microgram per kg per day. So you have to multiply with the weight. According to 75 international unit, you have to multiply with once if whatever she is having her weight. So according to that, you will adjust her dose. And they said that you can give her singly, or maybe the arrow may show that you can give as a single dose, or you can divide into two also, two divided doses. So it will depend upon the obstetrician choice and the hematologist choice that whatever the best for patient. If as a single there is any complications or any risk factors, so that according to that you will give as a divided doses. So now we will proceed toward the, as we have already discussed this in detail. Then after that, these are risk assessment and scores. If the First of all, we will check the scores that for that previous VTE they score 4, previous venous thromboembolism major surgery they will score 3, high risk thrombophilia score 3, medical comorbidity score 3, family history of first degree relative unprovoked or student related VTE that is score 1, low risk thrombophilia no VTE 1, age more than 35 score of 1, obesity 1 or 2 in case if BMI of more than 40, and it is less than 40 then only score 1, and if it is more than 40 BMI then score of 2, parity 1, smoker 1, gross veins and 1. So you have to also, the scoring system is they give both the scoring system and along with the normal assessment of risk factors. So you have to score, either you can score or you can directly according to risk factor. If 4 risk factor, then you have to start treatment on, you can also score that. So preeclampsia, all these are 1, only cesarean section in labor is 2 score, and the others are 1 score. And the transient risk factors are any surgery, so that is 3, hyperemesis 3 score, OHSS 4, current systemic infection 1, immobility 1. So then these are the how. If the total score of equal to more than 4, risk factor antenatally consider from first trimester. If score of 3, risk factor antenatally consider antenatal from 28 weeks. If total score equal to more than 2, risk factor postnatally consider thromboprophylaxis for at least 10 days. If admitted to hospital, antenatal consider thromboprophylaxis if needed. If readmitted to hospital when the perpurium, consider thromboprophylaxis. So they are almost same. Nothing different in that. We have already discussed. For patient with identified risk bleeding, the balance of risk of bleeding and thrombophoresis will be discussed in consultation with hematologist, thrombosis and bleeding in pregnancy. So these are the contraindication. Non bleeding disorder, for example, hemophilia, von Willebrand disease, and acquired coagulopathy. So you have not cautionally used the low molecular weight heparin. Active antenatal postpartum bleeding, patient with major placenta previa, thrombocytopenia, acute stroke within 4, you have to avoid low molecular weight heparin. Severe renal impairment, GFR of less than 30, severe liver disease, uncontrolled hypertension, BP of more than 200 systolic. So these are the contraindication. Then this one is the last table and very good table for memorize, that how to memorize, that we already discussed in the recommendation. So if you only do the recommendation and the summary and these tables, so that will enough for you for your exam, and it will easily to memorize these type of tables. So you not get the detail of all everything they have given later on. So what are the women with very high risk factors? Those with a previous venous thromboembolism or long-term oral coagulant therapy. Recommend high dose and low molecular weight heparin antenatally and at least 6 weeks postnatally, or until switch back to oral anticoagulant therapy. And those with antithrombin deficiency, antiphospholipid with previous VTE, women required specialist management expertise in hemostasis in management. As we have already discussed, that you have to discuss with expertise, and these type of with antithrombin or antiphospholipid with previous VTE, they need at least 25-50% or full dose of low molecular weight heparin. So you will involve the hematologist. They will decide that whether she need 25%, 50%, 70% or full dose of heparin. So in that case, they mention specifically that the expert is acquired. Very high risk are those, and only high risk are what? Any previous VTE due to major surgery, except on a single VTE related to major surgery. So recommend antenatally, and you will start or immediately in first trimester and 6 weeks postnatally. And what are the intermediate risk factor? Asymptomatic high risk thrombophilia, homozygous Factor 5 lead in protein C and protein S. Refer to local expert. Consider antenatal low molecular weight heparin and recommend postnatal for at least 6 weeks. These are the points that we have already discussed. I have told you previously that these are your SBAs. If you have for exam, if you have for preparation, so at last day you will just read this table, then it will be enough that all your MCQ will be gonna be all get good. Single previous VT associated with major surgery without thrombophilia, family history or other risk factors. So consider low molecular weight, but not routinely recommend low molecular weight heparin from 28 weeks of gestation and 6 weeks postnatal. So they said that you can consider antenatally, but usually not routinely recommend. Those that having single VT associated with major surgery without thrombophilia, family history or other risk factor. So in this patient you have to consider, not advise routinely recommend, but ideally you have to start her from 28 weeks and 6 weeks post. And low risk asymptomatic low risk thrombophilias, prothrombin gene or factor 5 laden, consider as a risk factor and score. Recommend 10 days if other risk factor and postpartum, or 6 weeks if significant family history or postnatal thromboprophylaxis. So those having asymptomatic high-risk thrombophilias, you have to refer to local expert. You will give both and advice both antenatally and postnatally for 6 weeks. But those are asymptomatic and low risk. Low risk are what? Heterozygous prothrombin and heterozygous factor 5. In this case, homozygous factor 5 and homozygous factor 5 and prothrombin. So in that case, the homozygous are more